Hello, I'm Dr. Keith Stussy, a member of the Clinical Practice and Clinical Recommendations team at the Traumatic Brain Injury Center of Excellence. As a Navy primary care sports medicine physician for 23 years, I had the honor of taking care of hundreds of active duty service members who had sustained concussions or mild traumatic brain injuries. I will be your guide for today's training, and we're hoping this video will help you become more familiar with the progressive return to activity process when treating service members with concussions. We'll start with a short introduction that sets up our first patient scenario. Throughout the remainder of the presentation, I will be asking you to make decisions based on the situation. Several possible actions will be shown, and we ask that you stop and think about the best choice. When you are ready to continue, we will review the best course of action together. Now, we know that we all learn from our mistakes, so please take the time to answer the questions before moving on to the next scenario. I recommend you have the Progressive Return to Activity Clinical Recommendation, or PRACR, available to refer to as a reference guide as we go through this case study. We like to have you pay special attention to the first three boxes at the beginning of the algorithm. Typically, the MACE-2 is performed prior to entering the PRA protocol. Often, providers that are outside the service member's usual medical facility, such as an emergency department or MTF branch clinic, will implement the MACE-2. Thus, we want to emphasize this by shading the box a different color. The algorithm provides guidance on how to return a service member to full duty following a concussion. This is an interactive document. You can click the appropriate links in each box for detailed instructions and additional resources. To navigate back to this page, use the Return to Algorithm button at the bottom of each subsequent page. Now, let's take a look at our case scenario. You are covering a unit football game on a Thursday morning as part of weekly PT. As you're watching the game, you see service member Jones lunge to tackle another service member, and he appears to hit his head on the ground. As he lays on the ground, someone yells out, "Corpsman up!" You and your corpsman rush onto the field to assess him. By the time you get there, Jones is sitting up and is alert. He tells you he's fine and wants to continue playing, despite the fact that he's holding his head in what appears to be obvious pain. He's moving his head, neck, and extremities, and seems to be conversing normally. Stop the video here and select the answer that you think is the next best step. Which did you choose? Send him back to the field? He's their best player, and certainly he can help his team win. Call 911? Unfortunately, neither of those are the best choice. Because he had a potential concussive event, you initially performed the MACE-2. While calling 911 is technically not wrong, because he is sitting up and appears to be lucid, there is no urgency to call 911. The MACE-2 can also help you rule out red flags and determine if a higher level of care is necessary. Knowing football is a high-risk sport for concussion, your corpsman brought a copy of the MACE-2 and has it in her uniform pocket. After you clear his cervical spine, you walk service member Jones to the sideline and administer the MACE-2. He admits to feeling dazed and confused for approximately 30 seconds after he hit his head. He denies any loss of consciousness and states he remembers the entire event. There are no red flags. He currently complains of a mild headache, dizziness, and nausea. You now perform the MACE-2 screening and complete the cognitive and neurologic exams. His overall cognitive score is 25 out of 30. During the neurologic exam, he has an abnormal tandem gait and single leg stance. Did service member Jones sustain a traumatic brain injury? Stop the video here and select the answer that you think is the next best step. Did you answer yes? I hope so. The service member clearly had a concussion based on the DoD definition of traumatic brain injury. The definition is shown on the screen. Note, the external force can either be a direct blow to the head or the result of a pressure wave that we see in blast injuries. In the case of service member Jones, He stated he was, quote, dazed and confused for approximately 30 seconds, which is alteration of consciousness, or AOC. In addition, he was witnessed to hit his head, which is clearly a mechanism of injury. Therefore, he meets the criteria for diagnosis of traumatic brain injury. Per the PRA algorithm, the initial concussion management includes providing concussion education, including these two fact sheets: what you should know about concussions and healthy sleep following concussion/MTBI, both of which can be found on the TBI COE website. In addition, you should manage the acute headache with acetaminophen for the first 48 hours, followed by the use of an NSAID. If necessary, more information can be obtained with the headache following concussion/mild TBI clinical recommendation, which can also be found on the TBI COE website. Lastly, review any current medications and supplements with the patient and initiate 24 hours of SIQ or quarters and schedule a follow-up visit with their PCM in 24 hours. Service member Jones follows up with you the next day and you repeat the MACE-2. He continues to have a mild headache, but his nausea and dizziness are nearly resolved. His score on the cognitive portion of the MACE-2 is 27 out of 30, and his neurologic exam is normal except for a continued abnormal tandem gait. Therefore, the result of the MACE-2 is still positive. What would you do next? Stop the video here and select the answer that you think is the next best step. The complete answer is seen in the PRA algorithm. You should have the patient fill out the NSI, which is a questionnaire that assesses symptoms associated with concussion. You should then discuss stage 1, or relative rest, with the patient and review instructions for progression, which are in the clinical recommendation. You then fill out and review the new Patient and Leadership Guide, or PLG, with the service member and make sure he understands he must submit it to his command, so they are aware of his diagnosis of concussion. Lastly, you schedule patient follow-up visits every 3 days to ensure close observation during the PRA process. As you can see, simply because the MACE-2 is improved does not mean the patient can return to full duty. All patients must successfully complete all of the stages in a stepwise fashion before they can return to full duty. Service member Jones appears to understand the PRA process, so you discharge him with appropriate duty modifications. Service member Jones has had 1 concussion in the last 12 months. Is it mandatory to refer to a specialist? Stop the video here and decide the correct answer. Since this is service member Jones's first concussion in the past 12 months, he does not need a referral to a higher level of care. In most cases, service members will completely recover and be able to return to full duty in approximately 2 weeks. Thus, the PCM should feel comfortable treating based on guidance in the PRA clinical recommendations, and immediate referral is not necessary. If this had been the 3rd concussion in the past 12 months, you would refer to a neurologist or other qualified provider for a comprehensive neurologic exam while also initiating the PRA protocol. During advancement through stages 2 to 5 of the PRA, be sure to have the patient complete the NSI and discuss instructions for progression at every visit. You can also use the symptom-guided management table to assist you in treating the patient's specific symptom clusters. Follow-up is recommended every 3 days until the service member is either ready to return to full duty or specialty referral is necessary. Now, let's fast forward to post-concussion day number 7. Service member Jones has advanced to stage 4 and is at the gym weightlifting. While attempting to increase his weight on the bench press to 135 pounds, his headache gets significantly worse to the point he has to stop lifting. He has a scheduled follow-up with you shortly after the incident and states he is unclear as to what to do next. What advice do you give to the service member? Stop the video here and select the correct answer. If symptoms worsen during an activity, The service member should follow the guidelines for relative rest until their symptoms resolve, and then return to the previously tolerated stage for the remainder of the day. Since Service Member Jones was last asymptomatic in Stage 3, and he felt worse today attempting to advance to Stage 4, he should go back to Stage 3 and continue progression as instructed. It is important to go over the stages and instructions for progression at each follow-up visit. Service Member Jones follows up 3 days later and states he got to Stage 4 again, but feels like his headache is not improving. In addition, you sense he is becoming very anxious about the fact that he is not fully recovered. He reviews medications, and he admits that he never picked up his prescription for naproxen and only took acetaminophen for a few days after he hit his head. Regarding the anxiety, he notes having similar issues several years ago when he had a concussion in theater. At this point, what would your recommendations be for Service Member Jones? Stop the video here and select the answer that you think is the next best step. While it is never wrong to refer to a higher level of care, we encourage PCMs to attempt managing symptoms in the first 15 days, and if they do not resolve, then consider referring to a specialist. In this case, he needs to restart his NSAID, and this will hopefully resolve his headache. In addition, there are several things the PCM can do for Service Member Jones's anxiety. Per the symptom-guided management table, you can see recommendations for treatment of anxiety and mood. Those include mindfulness, deep breathing, and relaxation, and also exercise is tolerated. Service Member Jones follows up in 3 more days, now 13 days post-injury, and says that naproxen resolved his headache completely. With the help of simple relaxation techniques, his anxiety is significantly dissipated. He spent the past 24 hours at Stage 5 and feels great today. At this point, what should you do at this visit? Stop the video here and decide the correct answer. Per the PRA algorithm, once a service member has completed Stage 5 for 24 hours without worsening or new symptoms, you can safely perform the return to duty screening. It is not necessary to wait any additional days to perform the screening. In the updated PRA algorithm, the return to duty screening is now comprised of both physical and cognitive portions, and the service member must pass both in order to return to full duty. The purpose of the RTD screening is to give the provider a way to objectively measure readiness for return to duty. The physical return to duty screening may be done in the office, gym, or PT area. Have the service member perform 2 minutes of supervised aerobic activities at an exertion rate of 16 or greater on the Borg Rate of Perceived Exertion or RPE scale. The Borg RPE scale helps estimate how hard someone is working, and one can multiply the RPE on the Borg scale by 10 to get a fairly good estimate of the individual's actual heart rate. Therefore, at a Borg RPE of 16, the service member's heart rate should be approximately 160 beats per minute. Preferred activities include modified burpees, sit-ups, or jumping jacks, as these activities will stress the vestibular system. Other activities include high knees, step-ups, push-ups, running, elliptical machine, or the exercise bike. Let's assume you perform the physical exertion screening on Service Member Jones, and he has worsening symptoms. What should you do? Stop the video here and decide the correct answer. If Service Member Jones has worsening symptoms while performing the exertion test, you should stop the test immediately, discharge him in Stage 5, and retest in 48 to 72 hours. You can refer to the primary care management strategies in the symptom-guided management table while awaiting retest. In addition, you should hold off on performing the cognitive testing until he passes the physical portion of the RTD screening. If the retest is abnormal, refer to a higher level of care based on the specialty referral section of the symptom-guided management table. Service member Jones comes back in 72 hours for another return to duty screening. You have him perform jumping jacks in your office, and he has no worsening symptoms after 2 minutes with a Borg RPE of 16. Per the PRA algorithm, once a service member has successfully completed the physical portion of the RTD screening, he or she must complete the cognitive screening. The cognitive portion is something new that has been added to the 2021 PRA clinical recommendation, and it ensures the service member is fit both physically and mentally prior to returning to full duty. The preferred neurocognitive assessment is the Automated Neuropsychological Assessment Metrics Test, also known as the ANAM. Ordering the ANAM is simple, and the ANAM is available at most MTFs. Appendix D in the PRA tells you how to request an ANAM. As you can see, you can either call the help desk at 855-630-7849, or you can email the request inbox at the address listed on the screen. There is someone at the help desk 24 hours a day, 365 days a year. Once you have ordered the ANAM, have the service member go to the nearest ANAM office to complete the test. Once completed, the ANAM results will come back to your email that you provided. This is typically 24 to 48 hours later. The interpretation will look like the ANAM interpretation graphic on the screen. As the graphic describes, if the service member has a baseline ANAM for comparison, refer to the reliable change. If any single domain is less than negative 1.64, or any two domains are less than negative 1.28, the service member must wait an additional 48 to 72 hours and retest. If there is no baseline for comparison, then refer to the composite score. If that is less than negative 1.64, then the service member must also retest in 48 to 72 hours. If the ANAM is not available due to deployment, or if you are in an austere environment, repeat the cognitive exam portion of the MACE-2, questions 5 through 16. The service member should score 26 or better in order to pass the cognitive exam on the MACE-2. If they fail the first attempt, as with the ANAM, they should retest in 48 to 72 hours. If the service member fails the cognitive exam on the second attempt, you should refer to either neuropsychology or speech-language therapy for further evaluation, depending on what services are offered at your MTF. Of course, the service member should remain at stage 5 until they have either passed their cognitive exam or have been cleared by a specialist. Now let's get back to service member Jones. You call the help desk and arrange for service member Jones to take the ANAM. Since the ANAM office is close to the aid station, you instruct him to go today and take the test. He successfully completes the ANAM, and the next day you receive his results in your email. He fortunately had a baseline from 2018 prior to his deployment, and therefore you are able to review the reliable change. No single value is less than negative 1.64, and there are no two values that are less than negative 1.28. Therefore, he has successfully passed the ANAM and the cognitive portion of the return to duty screening. He is now ready to advance to stage 6 or return to full duty. Congratulations! You've successfully guided Service Member Jones through the PRA process. I hope this helps you treat service members with concussion in the future. For more information on the PRA clinical recommendation, please visit the TBI COE website at health.mil/TBI COE. Thank you.